Hello, and thank you for joining Use of Peer-Reviewed Treatment Guidelines to Improve Prescribing and Small Animal Medicine, featuring Dr. Scott Weiss from the Ontario Veterinary College. My name is Nicole Cast, Continuing Education Program Manager for the Minnesota Veterinary Medical Association. The MVMA is pleased to be one of the hosts of the Antibiotic Stewardship in Veterinary Medicine webinar series, along with the Minnesota One Health Antibiotic Stewardship Collaborative. We're also working in partnership with the Minnesota Board of Animal Health, the Minnesota Department of Health, and the University of Minnesota's College of Veterinary Medicine. During today's webinar, the MVMA will provide technical assistance. If you have any questions during the session, please type them in the Q&A area. With that said, I'd like to turn the session over to our moderator, Dr. Amanda Bodine, Director of One Health Antibiotic Stewardship at the Minnesota Department of Health.
Great. Thank you, Nicole. Welcome to the Antibiotic Stewardship in Veterinary Medicine webinar series. I am Amanda Bedoin, Director of One Health Antibiotic Stewardship at Minnesota Department of Health, and also Adjunct Assistant Professor at the University of Minnesota College of Veterinary Medicine. In my position, I work with professionals in human, animal, and environmental health to improve how we use antibiotics and to lessen their adverse impacts while effectively treating infections. The Minnesota One Health Antibiotic Stewardship Collaborative is made up of folks just like you, professionals interested in learning and leading our state's multidisciplinary approach to stewardship. The collaborative has joined forces with MVMA to bring you a terrific lineup of webinars over the next 4 months. The expectation to be good stewards of antibiotics is real and present. This webinar series is intended to provide background on the problem of antibiotic resistance, the solution of stewardship, and to provide actionable information for all sectors of veterinary medicine. It is my pleasure to introduce our speaker today, Dr. Scott Weiss. Dr. Weiss is a professor at the Ontario Veterinary College at University of Guelph, a veterinary internist and microbiologist, and a diplomate of the American College of Veterinary Internal Medicine. He serves as Chief of Infection Control at the Ontario Veterinary College Teaching Hospital. Dr. Weiss's research interests include bacterial infections in animals and humans, methicillin-resistant staphylococcal infections, Clostridioides difficile, antimicrobial resistance, emerging infectious diseases, and infection control. Welcome, Dr. Weiss, and thank you for joining us.
All right, so I'm not sure how much you heard. Cut out again, let me know. I'll just keep on moving since we're going to burn it through a lot of time. So basically, I was talking about we've got the clinical consequences of antimicrobial resistance, but we also have the public health consequences of antimicrobial resistance through that direct interchange that we have of bacteria and maybe resistance genes between animals and people. And with companion animals, obviously, we have this close degree of contact that you'll probably all know since you're on the line. Now, I'm not going to get much into this, and I'll probably try to be fairly quick on it, but the concept of stewardship that you're all really aware of, but stewardship is this balance that we have between optimizing patient care, but also minimizing the adverse effects of antimicrobial use on the patient, on the animal population, on the human population. So maintaining animal health and welfare and maximizing human health at the same time. And it's tough because some of the things we want to do to improve one aren't necessarily what we want to do to improve the other. But if we look at antimicrobial stewardship, and you probably can't read this very well, but antimicrobial stewardship programs are very multimodal. They're a large bundle of different things that can be done, the individual effects of which we don't really understand very well. Good data on the impact of specific interventions to impact antimicrobial use or antimicrobial resistance aren't very good, but a lot of these are logical. There's some data behind some of them. And we've got a whole range of things that we can do. And within these, there are measures to educate prescribers, users, to measure how we use, how, when, why, where, to motivate people to do things that we want them to do, to facilitate antimicrobial use, proper antimicrobial use, to empower prescribers, to empower users. And sometimes, and it's a minor component, but sometimes has to be there to restrict. And a lot of these require some basic information, which is understanding how we use antimicrobials and require some guidance on how to use them. So if we look at just some of these aspects of stewardship programs, we've got decision support mechanisms to help with proper prescribing. We have disease-specific treatment guidelines. And these are human, but we can apply these in veterinary medicine as well. We have empirical treatment guideline options and surgical prophylaxis. So we have quite a few things that relate back to antimicrobial guidelines at the clinical level. And that's where a lot of effort's being put lately, is how to guide users to optimize antimicrobial use while maintaining animal care. Now, one thing that's always been an issue with antimicrobial use guidelines or prudent use guidelines, or whatever the name has been in the past, is the guidance that they give, the do something versus actually do this. And historically, we've had a lot of guidelines that have said, not a lot really, they've given us big picture, they're important, they set the scene, but they didn't tell us what to do at the prescribing level. And this isn't to criticize AVMA, because they're all different places in human and the animal side, but we talk about these high-level mother statements, use them only when they're needed, make sure it's the most appropriate, only use the correct dose, frequency, duration, which doesn't really tell a user how to prescribe antimicrobials in an individual case. And it also highlights some of the deficiencies we have from a research standpoint, is we just don't know what a lot of these things are. What is the proper duration? We have very poor data on antimicrobial use durations in the animals, especially companion animals. So these statements like this set the scene and raise some awareness, but ultimately they don't change what we do, probably because they don't give us guidance. And by default, we're defensive. So if we've used something in the past, we're probably going to stay there unless we've got something that will specifically guide us to change our practices. Now, if we look at some of the broader, I guess, more specific statements, you can see AAFP, AHA guidelines. Again, some of these are fairly broad statements that don't tell us what to use narrow spectrum antimicrobials whenever appropriate. Not a lot of specific guidance. Use culture and susceptibility. Yes, that makes sense. Therapeutic antimicrobial use should be confined to appropriate clinical indications. Yes, that makes sense if we know what those indications are and we know what those antimicrobials are. So as we've gone from, statements saying use them right to more defined statements saying what are the aspects of using them right, we've needed to have the evolution to say, okay, here's what to do or what you can do in the majority of cases. And like I said, this wasn't to criticize any of these groups, because this is common in the human side. You'll see educational campaigns like this still too, and they do raise awareness. The right reason, the right time, the right drug, and the right dose. That's good. It makes me think about how I'm using antimicrobials, how I'm prescribing, but it doesn't probably alter my behavior if I don't know what those are. If I don't know that there's support to change things. Anyone changing their practices puts their neck on a line to a degree. If something's been working and they try to make a change, it can be a scary thing. So there needs to be evidence-based support, or at least some degree of guidance that gives people the ability to make those changes. So if we look at the human side, the clinical practice guideline approach has been well established. They have the advantages of having larger groups, more established groups, and much more data to do this, but there are a variety. I didn't put many up here, I've got one. So practice guidelines for acute uncomplicated cystitis and pyelonephritis in women. These evolve, they're very well updated, and they're really excellent clinical guidance. And it's something that we've largely been lacking in the veterinary side. Although it's changing. In the last 10 years, a little under 10 years, we have seen the introduction of clinical guidelines that fit with the human approach, down to here's what you can do for, majority of your patients, not all your patients, but most cases that you see. A lot of these are related to ISCAID, the International Society for Companion Animal Infectious Diseases, who launched an antimicrobial guideline process, it was about 10 years ago, a little over 10 years ago, to provide specific guidance. I'm going to go through some of them. There are some others. I'll mention those as well. And this isn't, to advertise ISCAID, but to show probably the most advanced kind of broad treatment guideline approach. I'll go over how this is done in a minute, but the first guideline that we released was in 2011. These were guidelines for urinary tract disease in dogs and cats. And one of the disadvantages, like I said, we have in the companion animal field is we're limited in the data that we have. We have kind of approaches that we've done historically. If you trace back references, you find that there's not any support for it. And we have very limited data, though, to change those practices. If you look at human guidelines, you'll typically see an approach, such as this. There are various ways. There's a grade system, essentially looking at the quality of evidence, the strength of recommendations, and the quality of evidence. And this is becoming more and more rigorous as time goes on. Assessing individual papers for the risk of bias, the study design, to try to make sure that we're making decisions based on optimal data and that we're recognizing the limitations of the data that are out there. Now, so far, we haven't taken this approach with the ISCA guidelines for a couple reasons. One is we have very low level evidence. And most of our evidence assessment would rank very low. So there's not going to be a lot of variability. And they may come across as weakening the guidelines if basically everything's coming through at a low grade. Certainly, this is part of the informal process, evaluating strength of evidence, quality of evidence, strength of recommendations, but it's not come through with some of them in the human side where you have a recommendation and you'll see A1 or B2 because each of those recommendations has specifically been scrutinized with respect to the strength of the recommendation and the quality of evidence. We're not there yet in veterinary medicine. We probably won't be for a little while to be able to do that well because the data are lacking. So the approach is very much an expert-based approach. Expert opinion is very low on the list of evidence, quality of evidence, but it's on there. And in lieu of better data, we have to rely on expert opinion. We have to rely on extraction from other species. We have to rely on some common aspects or common sense components of infectious disease, antimicrobial use, and the like. So the approach to the ISCA guidelines is expert panel with a very broad group: internists, microbiologists, pharmacologists, people from the human medical field with experience in guideline development, general practitioners, dermatologists for the dermatology guidelines, trying to be international to make sure that we're not biased towards one region because practices can be different and they need to be relatively broad. These are typically made with a consensus approach. They're a very slow, somewhat painful process. The first urinary guidelines, I think, would have been about 2 years to submission for publication. We've done a revision of the urinary guidelines that took us longer than that. Part of it's because you have people that are very busy and it's on the corner of a desk. Part of it is because there's a lot of discussion that goes into it, especially as they get more and more comprehensive when you're dealing with limited data. So a consensus approach, multiple iterations, trying to come up with recommendations that are as strong evidence-based as possible, typically some type of vote on the recommendations, typically a review by an external panel of experts to make sure that there's not this insular approach to it, and then peer review for publication. So these, while they're based on a lot of opinion, go through multiple levels of checks and balances to hopefully make sure that they're as high quality as we can. One thing that's important to point out about guidelines, and this is a terminology thing, but I think it's an important terminology thing. Guidelines are not standards. Guidelines are, this is what you should do, in most cases. This will fit for the majority of patients that you see. Standards, especially standards with the big S, are kind of a thou shalt. This is the expectation. So we aren't trying to set standards. We're not trying to say that these guidelines are what you must do. We're trying to say these will help give clinical guidance. In the majority of cases, they'll be applicable. But there are some situations where they won't apply. There's patient factors, disease factors, maybe regional factors with antimicrobial accessibility. There are a lot of reasons why a guideline may not apply to every specific case. And certainly I deal with cases where I do things different than the guidelines because it's a strange case or a strange situation. So we're not trying to mandate care. We're trying to improve care by giving guidance. And it's important because we want to make sure that people aren't being felt that they're being steered in a direction that they have to go, but we're trying to improve their practices. So just a little bit of content on the guidelines. The urinary guidelines have probably received the most attention. They were the first ones that were published by ISCA. They're an area that's obviously a very big deal in small practice. A lot of animals treated for urinary tract disease, presumably a lot of overuse of antimicrobials, both in terms of duration and just indications of use. And there's been a lot of discussion of these guidelines since they were released. They covered 4 main areas: simple, uncomplicated urinary tract infections, complicated urinary tract infections, pyelonephritis, and subclinical bacteriuria. The latter, which was really one of the first times that this condition was being pushed to the forefront, of something to think about. The fact that bacteria in urine aren't necessarily abnormal and aren't necessarily always something that need to be treated. And that was probably the one that gained, among the most attention at the start, this revised approach, and had a lot of controversy at the time, but also I think changed a lot of behavior. So just some of the highlights. Actually, sorry, in the next version. So as we moved on to application of these guidelines, one of the things that we said fairly early in the process was, if we're not redoing these guidelines in 5 or 7 years, then we failed. Either we failed as a committee because we've just done this thing once and let it go, which happens a lot, or we failed as a profession and we haven't gathered more information. There were a lot of things that we said that, we think this is probably appropriate, but we don't have the data. As an example, for duration of simple uncomplicated cystitis, so routine cystitis, the typical approach had often been 14 days of antimicrobials, much longer than in humans. The comment was, well, 7 to 10 days, we should be able to drop it to 7 to 10 days. We could probably go lower, but we don't have the data to support that. And in the interim, some of those data have become available. So one of the things that really kind of struck people, I think, a lot was the differentiation of subclinical bacteriuria versus cystitis. So looking at disease as being what we're trying to treat, not bacteria. And like I said before, withholding treatment for subclinical bacteriuria created a lot of, I think, controversy at the start, but also led to a lot of converts once they started doing it and realizing the reasons for that. There was some decreasing duration of use, especially for what we called then the simple uncomplicated UTI, and an emphasis on first-line antimicrobial choices, amoxicillin, trimethoprim sulfa, which was a bit surprising to some people because we don't tend to use it very often in companion animals, plus or minus amoxicillin clavulanic acid, which is potentially overkill compared to amoxicillin, but presenting these as, here are the first-line antimicrobials to think about before moving to the next line. So like I said a minute ago, when we were writing these, we said, okay, we have to make sure that these are revised if we really want them to work. We shouldn't be using 10, 15-year-old treatment guidelines. We have to keep this fresh. So we launched a revision process, I can't remember the year, probably 2015 or so to start, because there was some data that were coming in, and because we, typically when you write something like this, you realize, oh, we maybe should have added that or thought about that. And so there were a lot of changes that we could see coming. And this is a fairly slow process. Like I said, it took a lot of discussion, we expanded into quite a few different areas, and we have much more comprehensive guidelines that expand on what was there in the first, but move into some new areas. So just some highlights on this. Terminology is important, and it's one of the things that we've been trying to emphasize. There's a lot of confusion around some terms, and that can lead to how antimicrobials are used. Urinary tract infection, that term is used quite variably in the literature to include cystitis, which is kind of what I always think of it as, but also it includes subclinical bacteriuria. There are various prevalent studies where you've taken a population of dogs, and you've collected urine samples from clinically normal dogs, and there are bacteria in the urine, and that's called a urinary tract infection. And one of the problems with that is it's subclinical. It may be completely irrelevant, but once you put that infection name to it, you lead to treatment, or lead to more pressure to treatment. So we're trying to move away from some of these vague terms, focusing on the disease, which is cystitis. Actually trying to get rid of not just simple and complicated, but trying to get away from urinary tract infection and move to bacterial cystitis. With the simple and complicated, that's the terminology that's used in humans. And one of the questions that we have in animals is there really such a thing as an uncomplicated infection, or is there always some underlying issue? The other thing that we've run into from terminology is complicated. Complicated has been used to define recurrent infections, repeated infections, refractory infections, a whole range of things. And the problem from an antimicrobial use standpoint is that's almost historically always defaulted to 28 days or more of antimicrobials because it's complicated. And some cases might need that, probably very, very few though. Because a complicated infection could be a dog that has compromised host defenses. It might have an anatomical defect or something that is prone to urinary tract infections, and it gets a lot of them. If it gets more than 3 a year, we've called that complicated in the past. But are these infections actually hard to treat? No. There is a series of run-of-the-mill infections that we can treat with a couple of days of antimicrobials versus something that's, a more established, complicated infection that would require longer terms. So trying to move away from that default saying, okay, they get recurrent disease, they're complicated, so you always have to go on 4 or more weeks of antimicrobials because 3 days of them probably needed, and the other 20-some days are probably not needed. Some other changes in the new guidelines. Like I said, I'm happy to talk details after if anyone wants. Further decrease of the duration for cystitis down to 3 to 5 days. Again, similar to humans, but also based on some evidence that's coming out in dogs. Not the highest level evidence. It's a very difficult area to get good research on, but evidence that is supporting shorter durations. Also, a decrease in duration for pyelonephritis, getting us closer to the approaching humans. One thing, again, that's, attracted a bit of controversy or attention was the consideration, the approach of, not using antimicrobials even for bacterial cystitis. Something that's been evaluated in humans where there's some data showing that ibuprofen can be as effective as amoxicillin for your run-of-the-mill bacterial cystitis, for controlling disease, for controlling the inflammation, and the body controls the infection. We're certainly not pushing a non-antimicrobial approach to all urinary tract infections, but it's a consideration. And just from my own standpoint, I'll use this in a couple different scenarios. One is the dog that can't tolerate drugs. So it has a urinary tract infection, has bacterial cystitis, and I would want to put it on an antimicrobial, but it vomits with amoxicillin and clavamox and fluoroquinolones or everything else. And I just don't have many good options. And the ones that are left I don't really want to use. Well, let's try some anti-inflammatories for a couple days. The other case where I'll use this, and probably the main place that I'll use it, just based on the strange caseload I see, is the animal with the highly drug-resistant bacteria. So maybe he's got an ESBL, where my main options are going to be an injectable drug. I don't really want to do that. The animal's otherwise fine. Anti-inflammatories for a couple days might be an option. So certainly not pushing, and certainly not saying that it's bad practice to use antimicrobials, and it'll be very niche population will be using this for, but introducing just some new concepts. Also, with the latest version of the guidelines, we got into a few new areas. Medical dissolution of uroliths. This is an interesting topic because there's a big difference geographically on how antimicrobials are used. If you look in the US, it's very common for people to use antimicrobials throughout the whole dissolution process when they're trying to dissolve based on diet. It's a long time of antimicrobials when there's no active cystitis there, on the thought that maybe there's some bacteria being liberated from the stone when it dissolves, but not really evidence supporting that. And if you look at some other places, Northern Europe would be a great example where it's very rare to use antimicrobials during dissolution, and they report successful dissolution. An area we don't have a lot of data on, but the low-level data we have doesn't really drive us to saying we need antimicrobials during the dissolution process if there's no cystitis. So a new area, and this is one that's attracting a bit of attention or a bit of dissent, just like some of our other topics. So if we don't, raise some issues, we're not going to advance the field. Also included surgical procedures, prostatitis, and a few different treatment options. Nitrofurantolin is a drug that we're increasingly having to go to for cystitis with multi-drug resistant pathogens. Fosfomycin less so, but another option. Both of these drugs being less important drugs in human medicine than a lot of the other options we would use for multi-drug resistant infections. So they're good options from that standpoint. Levofloxacin was actually a late entry to our drug list. And we certainly try to emphasize the importance of using veterinary drugs, veterinary fluoroquinolones, with the recognition there are a lot of people that use ciprofloxacin in dogs in the US because it's very cheap. We don't have that issue up here in Canada. Actually, it's not a very cheap drug here. There are a lot of animals that go on ciprofloxacin in the US because it's cheaper than the veterinary fluoroquinolones, but the bioavailability is very poor and it's highly variable. And susceptibility testing is not good because the breakpoints that are typically used are human breakpoints and they're inappropriate for animals. So we had some debate about adding a human drug like levofloxacin, but the idea, well, if you're going to use a human fluoroquinolone, let's use one that we know is bioavailable. And levo has a very high bioavailability. So this is always the debate. Do we add a drug in like that might drive more use of it by driving more awareness? Or do we have the benefit by at least shifting towards more effective use if people are going to use an off-label human product? And certainly you can make some arguments both ways, but we opted to put that drug in. Now let's do a quick one through urinary. Like I said, happy to chat about it after. There are a couple other guidelines out through ISCA and some other guidelines as well. Dermatology obviously makes sense because of the frequency of antimicrobial use in superficial folliculitis or pyoderma. These guidelines were headed by Andy Hillier and go through with a lot more emphasis on diagnosis and obviously treatment of superficial folliculitis. So like I said, there's a lot of discussion on diagnosis, and as there is in the urinary guidelines, because part of it's picking what drug you use, but part of it's only using antimicrobials when we have to, and only using systemic antimicrobials when we have to. So a fairly extensive discussion on diagnosis. And one of the big points with the folliculitis guidelines were, emphasizing the lack of need for systemic antimicrobials. in a lot of cases. With superficial disease, we have the advantage that we can treat topically. So there's quite a bit of discussion on topical antimicrobials, positioning that as an acceptable first-line treatment. And one of the things that we've seen just anecdotally from these guidelines and from the urinary guidelines is people that have come up to me at least and said, well, I'm glad that we got those guidelines because I always wanted to do that, but I was a bit afraid to do it because I thought, if I didn't treat subclinical bacteriuria and something happened, it'd be my fault. I'd be in trouble. Or if I just used shampoos for pyoderma, I'd be in trouble because everyone uses systemic antibiotics. And now we've given them an out because we've got published guidelines that say these are acceptable options. So that's kind of an aspect of how we get compliance is we're actually just supporting some people what they really want to do. Some people are trying to change their behaviors and get them doing a new thing. So we're approaching different audiences. But with the pyoderma guidelines, emphasizing the importance of topical therapy, the usefulness of topical therapy. And then respiratory guidelines that were published in 2017. Respiratory being a fairly broad group of diseases in dogs and cats. This one covered acute and chronic feline upper respiratory tract infections, canine infectious respiratory disease complex or kennel cough, bacterial bronchitis, pneumonia, and pyothrax. And I'm not going to go into the details because each of these guidelines is an hour talk basically. But one difference with the latest version of the guidelines, so the respiratory guidelines was a more explicit discussion of the expert review panel and reporting dissent that was there. So at the end of these guidelines, as with the other guidelines, they were sent to a panel of independent expert reviewers that had no involvement in the process, but were experts in respiratory disease or urinary tract disease. And with these, we reported the disagree votes and put that in there with an explanation of why. So you can see the statement on the slide here. Optimal duration of treatment for dogs with bacterial CIRDC is unknown, and the 7 to 10 recommendation was based on the clinical experiences of the working group because we have no data. Of the 17 reviewers, 15 agreed with it, 2 disagreed. One said if there's not evidence of pneumonia, in the cases of high risk for pneumonia, antibiotics aren't required at all. This is a subset of the population, not all are kennel cough. These are more advanced or chronic disease. But this one still took a middle course. Even in those situations, you may not need them. The other reviewer has concern about doxycycline because we don't have established breakpoints in veterinary medicine. So we don't technically know what's resistant or what's susceptible. So trying to be as transparent as possible in terms of what people thought and what areas of dissent were there. That said, the vast majority of recommendations don't have statements like this because there wasn't dissent recorded. Now, like I said, it's not all about ISCAID. There are other guidelines that are out there. There were some veterinary cancer chemotherapy guidelines that are interesting that were released last year. A more niche area, but a population where antimicrobial use is very common because of neutropenia, fever, gastrointestinal disease. So a small population, but one that could potentially be addressed with better guidelines. There are some other dermatology guidelines out there. It's just from a year or two, I think, predating the ISCAID guidelines. A pair of papers, one focusing more on diagnosis and one focusing more on treatment for bacterial skin infections. And then you get to the national guidelines. And the national guideline approach is interesting because it allows to tailor approaches to the drugs that are available to resistance trends that differ because the prevalence of resistance is quite different in, for example, Scandinavia versus the US. A lot of these guidelines pilfer, maybe not the wrong word, but adapt quite heavily from ISCAID or other guidelines because guideline development is a very difficult, very time-consuming process, and why reinvent the wheel if you have a good foundation? So a lot of these will take the available guidelines and make any changes as need be based on geographic realities, drug availability, drug restrictions that are present in some countries where they can't use certain antimicrobials. And there are a few examples. There's Denmark, New Zealand, Australia. Australia has some really good guidelines, fairly comprehensive. In Canada, there's another effort to revise what's called the prudent use guidelines, including companion animals, largely adaptation from the ISCAID guidelines, with a few Canadian twists on them. So the national guidelines maybe had the advantage too of being able to institutionalize antimicrobial stewardship, making it a little more of, start getting towards the standard when you get national guidelines. We still don't want them to be approached as standards, but you get more towards this is how we do it in the country. They can be associated with mandatory continuing education that's present in some areas, and get more discussion of the area. And we'll see more and more guidelines being developed, some just based on adaptations, and some based on new developments. Now, a couple of the things that I just wanted to bring up that aren't guidelines, but they sometimes get interpreted as them, and there's a bit of a concern here. And I'm not sure how many are familiar with the target book. This is certainly nothing against Antec, the lab this is based on. So basically what the target book is, you can find this online. This is a screenshot I took the other day just to make sure it was up to date. So urinary tract infection, lower urinary tract infection in dogs. And so we'll tell you what antimicrobials are good, bad, and ugly, basically, for different organisms and overall. And, I guess I try to temper what I say, but it's crap from a clinical standpoint. Like I said, the lab results are really good. I trust the lab. I trust the data they have. And if I want to look at their results and I see E. coli dominates, yeah, that makes a lot of sense. The problem is we have profound bias in data sets. Data dumps are easy. And the way this is obtained is they take a look at the culture results that are in the laboratory. Okay, what percentage are susceptible to amoxicillin and clavamox and reflux and the like? And we'll determine whether these are good, bad, fair, ugly drugs. Problem is, what percentage of urinary tract infections get cultured in dogs? Very, very small, right? And who gets cultured? Well, the dogs that failed amoxicillin, clavamox, the dogs that failed therapy is the mass majority of dogs that get a culture. So not surprisingly, amoxicillin is poor. Amoxicillin clavulanic acid is poor. Doxycycline is poor. Cephalexin. So a lot of the drugs we're trying to push towards using from a narrow spectrum good urinary drug come across as poor. Potentiated sulfas are good, but they're not a class that we tend to see used a lot, even though it's one of our first line options. Well, what's excellent for UTIs? Amikacin, imipenem, and meropenem. Certainly the last drugs that we're going to want to use for a routine lower urinary tract infection. And if you sort it by, so only the, kind of the main recommendations, you get enrofloxacin, marbofloxacin, and potentiated sulfas, not the beta-lactams that we want to use. And you can see different things. If you go to deep pyoderma, what deep pyoderma is cultured? Well, probably more of the methicillin-resistant staphylococci that have failed therapy, or dogs that have had repeated antimicrobial therapy before they get there. So again, we're getting a biased sample size, and you're not going to jump to amikacin as your first-line treatment in a dog with pyoderma, even though that's what these data show. So, and chloramphenicol and enrofloxacin, chloramphenicol comes up as good, and enrofloxacin comes up as fair if you click on the show only drugs and doses to consider. Certainly not going to recommend them empirically on these. So data are useful, like antimicrobial resistance data, data dumps, they can be really easy to get. They can be really hard to interpret, and they can be profoundly biased and they're not guidelines. They're really useful to look at trends. If we see changes in rates, especially if sampling hasn't changed, that can tell us a lot. If we're looking between regions, if we're saying sampling approaches, it can tell us a lot, but it can't tell us individual patient care unless we have data that are based on almost all patients with that disease. So if everyone with this disease gets cultured, that's great. If it's a certain practice, an individual's practice, and they culture all their UTIs or all their pyodermas, they can develop their own antibiogram, and it can tell them a lot. If they only culture 1 in 10, the refractory difficult cases, then it can't. So antibiograms, data dumps can be useful, but they don't usually have a direct clinical use. They're more of a research and surveillance tool. And they're easy, certainly not effective. Now, one of the questions that comes up is, well, did you do anything? You spent a lot of time doing these guidelines. What happened? Did you change things? And it's a really difficult question to answer because it's a really difficult area to investigate. If you look at the human side, there's been a lot of work on this. The human stewardship field is way ahead of the veterinary field overall in terms of the surveillance programs they have in place, the implementation of stewardship programs. And you can pull up various studies where it showed that, yes, we brought in an intervention, whether it was a guideline or something else, and we saw sometimes a decrease in antimicrobial, sometimes not. But certainly good examples where guidelines, especially guidelines that were fairly rigorously applied, resulted in decreased antimicrobial use or shifting antimicrobial use more towards the recommended groups. So for urinary tract infections, we wouldn't necessarily expect to see a decrease in antibiotic use, but we'd like to see a movement more towards amoxicillin and away from things like fluoroquinolones and third generation cephalosporins. So it's not just the amount of use, it's the drugs that are used. And another example, looking at, here's the trend with cephalosporins and macrolides. That dashed line is where the drug use was predicted to go based on trends. The solid line is where it looked like it was going. So they can have an impact. How to get them out there, how to apply them, how to measure is the big challenge. And one of the things that we really have to wrap our heads around is, what are we looking for? So we're making up guidelines. What is our outcome measure? Ultimately, what do we want to see? Well, we want to see less resistance in animal pathogens and human pathogens, right? That's why we do stewardship. We're worried about animal health and public health. Very, very difficult targets to hit. So at the highest level, we can say, okay, is an outcome measure awareness? Because people know they're out there. And, it's a reasonable thing to start with, right? Because if they know they're out there, at least you're getting some of that information, getting some of that awareness. That's maybe an easier thing to measure. And there's abundant anecdote on that. Can we look at antimicrobial use? Well, that's, relatively easy and relatively, a relative term. We're dealing with a large data dump from clinics across North America looking at urinary tract infection patterns. So antimicrobial use for urinary tract infections in dogs and cats. And what we'd like to do is roll out an intervention and see if that changes. It's very difficult because data tend to be very hard to get for antimicrobial use, especially the defined level of duration, dose, and why is a really difficult thing to get. And it's a challenge in the human side. It's especially a challenge in community health in people. Hospital data dumps are easier to get. Community health in humans is a challenge. The equivalent in animals is a challenge. So antimicrobial use is still a good proxy. Just because we look at antimicrobial use and we see changes in use doesn't mean we have any downstream impact on resistance, but we're going on the assumption that changes that we think are good, so moving towards more of the older narrow spectrum antimicrobials, reducing antimicrobial use overall will have a positive impact on that, but we're making some assumptions there. Looking at antimicrobial resistance in animal pathogens could be a challenge. Just based on the incidence of antimicrobial use, so finding out the population level will be a challenge. Same thing with zoonotic pathogens, and trying to pull out an intervention that influences antimicrobial use in a dog or a cat that ultimately impacts resistance in human clinical isolates. That's a big target, right? Ultimately, we'd love to do that, but it's going to be a very difficult study to what do we look at? How do we look at it? Are we looking at the impact of antimicrobial use in animals on resistance in Campylobacter and human campylobacteriosis? It's going to be very, very difficult if we ever get really good data on that. So we have to go at from the standpoint is we're making guidelines or bringing in stewardship programs to do logical modifications of antimicrobial use on the hope that what we think is logical actually makes sense and has a benefit. Back to the awareness side. These are just a couple, and this is a really, really crude measure, but it's an easy crude measure. We start to look at, okay, how are these guidelines being, recognized? And we can look at that at various levels. We can look at how it makes into things like the published literature, which is the easiest thing here. Here are the superficial folliculitis guidelines cited by 112. That's actually a very good citation count for a veterinary paper. It doesn't tell us that people are changing behavior. It doesn't tell us that what that citation means, but it means that there's some reach. We have no way of capturing how often they're mentioned by experts in conference presentations, which is maybe one of the bigger impacts on things like VIN, where there are a lot of clinical recommendations, although anecdotally I can tell you the SK guidelines get mentioned all the time there in the urinary one. So we can look at some really crude measures. Respiratory guidelines are newer, 30 citations. What does that mean? Don't know, but people are paying attention to it. Urinary tract, we've got more, and certainly there's a lag that has to happen, right? Paper has to go out there, someone has to read it, it has to make it into another paper that gets published. So it does take time for these to have an impact in measurable metrics of publication, but I think it shows that they're getting out there, and at least there's some awareness. Now, with our urinary, the most recent urinary guidelines, I'm trying to move the thing I've got there on my screen so I can see what we've got here. I pulled this up, it's Saturday, I think it was. So these guidelines are fairly new. They're a May publication. And we had 30 captures and 164 social media engagements, however they monitor them on Saturday. And then when I looked at them again yesterday, they're up to 35 and 224. So Does this have an impact? We don't know, but it's getting out there, and the social media spread is very useful. When we put these out on my website, a website called Worms and Germs blog, which is a kind of an educational infectious disease site, we had about 2,000 engagements within 24 hours of mentioning the guidelines were out there. So it does get out there. It's getting to various audiences. We're getting owners that are actually becoming aware of them too. And the odd veterinarian that gets asked by an owner about guidelines. So it's a slow process, just like it is in the human side, trying to get user engagement, both user at the prescriber level and user at the patient or the patient owner level. But it's something that's happening over time, especially as we get more social engagement. So if we look at outcome measures, like awareness, I think we can say we're getting awareness. And anecdotes aren't data, but we've got lots of anecdotes saying that these are fairly well recognized. I can't go to a conference without lots of discussions about ISCA guidelines. Usually good, sometimes some concerns, but awareness, I think, is coming out there. Antimicrobial use, I think anecdotally, again, we have a lot of people that talk about how they've changed their antimicrobial use patterns. Do we have data on that? No, not yet. And it's a challenge because there aren't many people working in the field. The other three, looking at resistance, like I said, that's a really hard target to get. And just to wrap up, this isn't the peer-reviewed guidelines, but it's just showing other efforts that can be done, because we can talk about kind of broad guidelines, and we can talk about some low-hanging fruit or small initiatives, because we're looking for things that will influence behaviors. Some of these may be really time-consuming, in-depth measures like making a guideline. Some may be potentially low yield, but really cheap, easy, free, fun approaches. Now, this is more towards the long-term kind of time-intensive one. And this is a food animal one. It just shows an example of things that can be done and some of the behaviors that come along with this. So one thing we know from dairy calves is that dairy calves get diarrhea all the time when they're young. And, the prevalence of upwards of 100%. And antimicrobials are used very, very commonly. We don't throw antibiotics at every baby with diarrhea, but we throw antibiotics at every baby cow with diarrhea on some farms. And this gets into some of the defensive medicine approaches and the behavioral aspects. If you talk to people that take care of the calves, what's that person's job? Well, their job is to have a healthy calf, right? So what are they going to err on the side of? They're going to err on the side of antibiotics. Because if that calf dies and they didn't give him the antibiotic, they're worried it's going to be their fault. Even though you talk to me and say, okay, well, we know we probably don't need to use them, but I'm going to use them because, I don't have anything else to do. So we implemented this algorithm on some farms in Ontario. And, there's nothing rocket science to it. It's the calf have a fever? Is it bright alert? Is it drinking? Is it dehydrated? Some very easy things that you don't need to be a veterinarian to sort out. And it led to monitoring or electrolytes and NSAIDs or antimicrobials. And we had farms that let us roll that out. And what we saw was we had a fairly pronounced and sustained reduction in antimicrobial use. Most farms, we had very major drops, 80% or so on some farms, especially on the high antibiotic use farms. So, and when we talked to people, a lot of it was kind of like the ISCA guidelines I mentioned before. Okay, we're glad we have them because we really knew we didn't need to do it, but we didn't have the bravery is maybe not the right word, but the willingness to do it. And we also gave them an out, right? So if you look at the calf person whose job is to have healthy calves, well, if they make a call not to use an antibiotic, they're putting their neck on the line. Just like if a clinician makes a call not to prescribe an antibiotic, we're putting our neck on the line. This is saying, okay, you don't have to. So, to blame the algorithm, not blame the calf person. And importantly, with this algorithm, we showed that we dropped antimicrobial use, and it was sustained, and there was no impact on morbidity or mortality in the calves. And we've had some of these farms ask us for other algorithms for things like respiratory disease because, they want to use fewer antimicrobials and they just want more guidance. And just another really small one, this is kind of blatantly pilfered from some human guidelines for urinary tract disease, but if it's just a sneeze, let it be. So approaching feline upper respiratory tract infections, trying to say, the majority of times we don't need to use antimicrobials. There are a lot of little things that we can do that may have very little impact, or may have impact just in certain situations. But if we can do them very easily, cheaply, and if nothing else, we raise some awareness, that can be highly effective. As you see in the human side with some of the programs that are meant to do things like this, just have a really easy awareness, things like non-prescription pads, things like basic info sheets that are designed to educate and inform the public and the prescriber at the same time. So I think we'll probably see more things like this that come on along with guidelines in the near future. Like overall, I say like it's not rocket science. Realistically for me, what I often say is the science is easy when it comes to antimicrobial stewardship. We've got a lot of gaps in evidence, but we've got enough to know what we should probably be doing, or what we can do to improve it. It's not convincing people of the data that's the issue. It's convincing people to change behaviors. It's the social science aspects. We're good at the medicine side. We're good at the surveillance. We're good at antimicrobial resistance. We're good at clinical aspects, but we aren't as good at anthropology and governance and a whole range of things that come into what drive people's behaviors, what drive their access, what drive their willingness to make change or communicate change. And it's that social science aspect that is probably the big thing we're missing in guidelines or stewardship overall. So I've got my email at the bottom there if anyone wants to follow up with questions. I said I tried to leave a reasonable bit of time. That got cut down a bit, but I'm happy to stick around if there are any questions about the broader process or the specific details.
Thank you, Dr. Weiss. A reminder, if you do have any questions, please type them in the Q&A area at this time. If you haven't already, our next webinar in this series will be Tuesday, June 18th, Antibiotic Stewardship in Production Animal Medicine, Regulations and Practice, presented by Dr. Mike Apley from Kansas State University College of Veterinary Medicine. Let's see, I'm not seeing any questions just yet, but we will give people just a moment to type them in. In the meantime, I'd also like to thank all of you attendees for logging in with us today and also bearing with us through some of our technical difficulties. After this session, I will be emailing you out an evaluation. Greatly appreciate it if you could take a few minutes to fill it out. And then we will also send you your CE certificate. I'm not getting any questions at this time to me personally or in the Q&A section.
Dr. Weiss, this is Amanda Bedoin. I can maybe ask a question since I have the open mic here. So I'm just curious if a small animal clinic wanted to implement maybe one of the ISCAID guidelines at a clinic-wide level, what are some of the pieces that you think might need to be in place? For example, just having commitment at the leadership level, but then also particularly from the standpoint of tracking compliance with best practice guidelines and measuring change in antibiotic choice in prescribing. Are there any do you have a brief suggestion for clinics that might want to implement this maybe at the first level?
Yeah, I think a lot of the thing for implementation is just awareness. We don't know what interventions work. What we're hoping to do, and I'm sure we'll be able to do it or not. I mentioned we have data from a lot of clinics on antimicrobial use. What we're hoping to do is try a couple of different intervention approaches. One would be, just here's the guidelines, look at them, and one would be here's a webinar. And one would be, okay, maybe I go there in person and we talk about them to discuss any of the questions and concerns and try to figure out what has an impact. I think a lot of it's just awareness, right? Everyone's busy. Not everyone takes time to read. Well, no one takes time to read everything. And this might be low on the list of people's goals to read. So going through and just picking one. So the guidelines are pretty comprehensive, but easy ways to start with baby steps. So let's just think of bacterial cystitis because it's very common. We use a lot of antimicrobials and we use them a lot longer than we need to. And trying to drop antimicrobial use, I think with those guidelines, we can drop antimicrobial durations and we can tailor it more towards our first line drugs fairly easily. So that might just be, let's just talk about, just 2 pages of the guidelines. Let's see what we're doing. What does everyone use for UTI? Why can we go with, the ISCAID recommendations, or at least get closer? So if you go 14 days with a 3rd generation cephalosporin all the time, well, let's try to get you down to, let's switch you to a penicillin, or let's drop it to 7 days, and then maybe in a few months you can get more comfortable and drop it a little bit farther. Some of the stuff does take baby steps, right? People are willing to make some change, but not complete change. So you go from 14 days to 7 days, that's great. Maybe next year we'll get you down to 3 days. Evaluating the impact is tough because most medical record systems aren't very good at dumping prescription data, especially really refined prescription data. to let us figure out why the antimicrobial is being used. It's getting better, but systems aren't really designed for that. So I think the way people are going to identify it at their own practice level, if it's doing anything, is just understanding their own behaviors. If they know that, okay, I'm prescribing differently than I used to in the past, and I'm comfortable doing that, that's a first step, because that also starts to make advocates. We've certainly developed a lot of advocates in practice that were the early adopters, and certainly talk to their colleagues, in the practice are out about short durations and not treating bacteria. We have some that are pretty vocal about moving on to some of these approaches. So you need to get some advocates, people that are comfortable doing it, and then hopefully everyone else comes along. Let's see if there's a question there. For a UTI in a female dog or cat, would you suggest amoxicillin at a higher dose? I don't think you really need a higher dose. It's just an appropriate dose. So amoxicillin, we get great levels in urine. Don't get great levels in tissue, but if we're talking cystitis, infection of urine and uroepithelium, the other thing with amoxicillin, you've got a really short half-life. So, if you've got a drug with a 40-minute half-life, if we increase the dose that we give by 50%, we're only getting another, 20 minutes above MIC. So that's half of a half-life. So we're only bumping things up a little bit. Increasing the dose doesn't really help us a whole lot, because we get a lot there and it goes away fairly quickly. So yeah, amoxicillin is a great choice for UTIs and cystitis in general. Where I end up moving beyond amoxicillin is cases where I think there's tissue involvement. So we've got a really abnormal bladder wall or maybe some invasion there. We start thinking about tissue active drugs. Pyelonephritis, obviously we're dealing with renal tissue, but 3 to 5 days of amoxicillin is my standard approach to cystitis.
Thank you. We have another question that came in. What do you think of the use of the next generation sequencing to determine resistance genes and guide antibiotic use?
Yeah, it's pretty useless. There are a couple issues there. Next-gen sequencing of urine is exceedingly difficult. We do it on a research standpoint because there's urine microbiota, and there's also a lab microbiota. One of the challenges that we have, if you give me a urine sample, I'm going to identify lots of different bugs in it. A large percentage of those came from the air or my lab or the reagents. And, when we're doing next-gen sequencing on, a fecal sample, all those get drowned out by the bugs in the poop. When we're dealing with urine, we don't. So next-gen sequencing, looking at that microbiota, doesn't tell us. Next-gen sequencing, looking just at an organism, so let's say you grow an E. coli and you do next-gen sequencing to pull out the resistance genes. Well, yeah, you can do that, but it doesn't really do anything, because with susceptibility testing, we know how to interpret it. And really, the vast majority of cystitis cases, we don't even need that. Culture is never a bad thing, but for me, the majority of dogs that have cystitis don't need a culture. Certainly I would never say don't do it, but if it's $100, $150 to culture, I've got a dog that's not been on antimicrobials before or very often. It's an otherwise uncomplicated case. It's not been a frequent flyer on antibiotics and doesn't have many other issues going on. It's going to respond to amoxicillin almost always. So I'd rather save the money for something down the road on this animal than put money in a culture, because I'm also going to get the culture result back probably the same day I stop the antibiotics. Yeah, and if they fail treatment, you always say, I wish I had a culture. But in a situation where you've got a very high likelihood of treatment success, culture becomes less important. So I focus culture or any diagnostic testing on situations where treatment failure is more likely. So next-gen sequencing, there are a lot of great things we can get out of next-gen sequencing, but we just don't have many right now that we can apply clinically. Question on how do you figure out how often to give twice or 3 times a day based on half-life? I'm sure this is referring to amoxicillin. I would suspect it is. We had a lot of discussion about amoxicillin dosing, like months or years of discussion with the latest version of the guidelines. In the original guidelines, we said 3 times a day. We've changed in the most recent version to say twice or 3 times a day, which at face value might look at it and say it doesn't make a lot of sense to recommend twice a day on a drug with such a short half-life, and it makes no sense for tissue. But when you've got urine where you get so much drug into the bladder, it actually does make sense. There certainly are mixed opinions on whether twice or 3 times a day is the best approach for amoxicillin, but twice a day for cystitis certainly does seem to be effective. And there definitely is a compliance issue. We are looking at some behavioral aspects of owners, what they'll tolerate in terms of twice or 3 times a day. Another advantage, kind of getting off topic of the short durations, is compliance, right? If you recommend 14 days of antibiotics to a dog with a urinary tract infection, it's feeling better after a day or two. I'm sure our compliance plummets after a couple of days because the clients don't see the benefit and the animal gets much more resistant to being killed. So we probably get a couple of days of good treatment, and then we get sporadic treatment versus, short-term therapy. We can focus on if it has to be 3 times a day, we can, suck it up and do it 3 times a day for 3 days. So short courses can help with that. But yeah, back to amoxicillin, the recommendations are twice or 3 times a day. And for, a simple cystitis, I think twice a day, we've got reasonable evidence that it's fine.
I think the only other question I'm seeing come in is asking about guidelines planned for acute diarrhea.
Oh, great question. Yes, underway. Not ISCAID, although we're working with them. So there's a European group through ECMID, their Clinical Microbiology and Infectious Disease, the overarching group, their veterinary group, GI. We have a very, very slowly moving. It kind of got delayed because of some other group efforts, but there will be a relaunch of that. Realistically, it's going to be a couple of years as the second for things in publication. It's a tough area because we have a lot of antibiotic use, and we've got a very ill-defined disease being chronic diarrhea, which is lots of things. But that's definitely very high on the list of things that we need some guidance for because of the amount of antibiotic use that's there. So yes, there will be something coming. Presumably, I would look for it for hopefully something we can start presenting about in the next year to get information out there. Probably not much sooner than that.
Great. Thank you so much. I'm not having any other questions come in. Dr. Bedoin, do you have any to you?
No, I think that's it. Thank you so much for presenting to us today, Dr. Weiss.
Yeah, no problem. Thanks for having me.
Everybody have a great day. Thank you.